start recording. Good afternoon, everybody. Today we are having Mr. Jared Onsuma. Mr. Jared Onsuma is a software engineer in the Ministry of Health as ICT tech lead. Jared has been doing a lot of work at the background to enable us Kenyans in totality, especially in public health systems, to have one platform which is known as digital health platform. So today Jared is going to give us a brief overview of the system, of the thought process, and shed light to the many works that he has done. Jared, good evening, good afternoon.
Good afternoon, and thank you very much, Doc, for this opportunity. Yes, this afternoon we are going to discuss about digital health platform, but more specifically on interoperability and integration of health systems. Thank you. So I don't know whether I need to go ahead and share my slides.
Kindly. Thank you very much, Jared. We are the ones who are humbled to have you here on our platform. So thank you very much.
Okay.
You can share and take us away.
All right. Let me see. I hope you can be able to see my shared screen. Hello.
It's just yet to be clear, but it shows that you're sharing the screen.
Or I can share the document to you, then you can.
Whichever way, and I'm okay.
Let me just share. I don't know why it's not sharing from my end. So I've shared it on your email. It again.
Okay. Yeah, so while we're doing that, maybe you can clarify what is digital health platform? What is, yeah. What came about from there?
Yeah, so thank you very much. As we sort out the issue of sharing my slides, first of all, as you heard, my name is Jared Onsuma. I'm an ICT officer at the Ministry of Health, leading the digital health transformation within the ministry. And a lot has been happening in this digital space. And as you are aware, the digital technology is really just to facilitate the end goal of ensuring that the quality of care is really improved. And for us to achieve this, then we've taken several steps in a way that then we are able to promote quality of care to our clients, who are the patients, who are the facility. And one of the biggest concerns that has been there is the integration of the systems. You go to a facility, they say they are automated, but they say they're automated, but you find that they have disparate systems for different services. For example, you can have a lab system, you can have a pharmacy, you can have a clinical system, a payment, registration, imaging, and all these systems, yes, they are working within a facility, but they are not really communicating. And even within a given visit of a patient, you cannot be able to tell the services that this person has received from a glance, because these systems are not talking to each other. And so that is one of the gaps that we are trying to deal with. And to do that, as a ministry, come up with a digital health platform that is an end-to-end platform whereby you are able to track patient from the point where he gets to the facility to the point where he exits. It's a transactional system, and it's really patient-centric. system. And so with that, then you're able to track where the patient has moved from one point to another. And therefore, there are some modules that are going to be globally available. We are talking about registration module, so that then once you are registered at a given facility, your information is going to be globally available across other facilities. Why this is really important, because remember, there's the question of unique patient identification. Without that unique patient identification, you cannot be able to longitudinally be able to track medical history of our patients. But with the unique patient identification, and it's being used consistently across different service delivery points, across different facilities visited by the client, then now you'll be able to have this information. And once you have this longitudinal medical information of the patient, then you are able to really make informed decision as you serve. Even the turnaround time that you take to be able to serve this patient is going to be really reduced. So the system has the registration, the clinical aspect, the lab, the pharmacy, the inventory, and some of the things that the system is going to address is of course, one of them is the quality of care, which is really important because the information is available wherever the clinician wants it. And therefore, serving this patient is going to be serving the patient from the point of knowledge with proper information. I usually give this example whereby our patients, the way they behave, once they feel and when they go to a facility, of course, they are taken through the process whereby the observations are made, investigations are requested, they are conducted, conclusions are made. Then after that, prescription is given, the patient goes home. And after a week after
sorry for interrupting your thought process. So I've already set up the slides, and I'm listening if you want me to move.
Thank you very much. So let me just finish the introduction of the DHP bit, then we focus, because today's presentation is really on the integration and interoperability, what steps we've taken to ensure that then this is achieved within the sector. But as I was saying, with my example on DHP in terms of quality of care, so after the patient comes back, he goes home, taking the medication and he doesn't feel better, most of the patients will go back to the facility, but more likely they will visit a different facility. And at this point, they don't have any information with the kind of prescription that was done, the kind of investigations that were conducted. So when he goes to the clinician, of course, he will mention, yes, I went to the facility, I was given a medication, which is not sure kind of medication, the kind of tests that were conducted. At this point, that information is not available. So because that information is not available to the healthcare worker at that point, the healthcare worker might end up actually requesting for the same set of investigations, end up doing the same set of prescription. And so you can imagine at this point, we are not helping this patient in terms of quality of care, because it's the same medication that he's been taking. And so we are not helping the patient from that perspective. There's the question of costs. You can imagine now requesting the same set of investigation that were conducted a week ago. If you had this information, you couldn't have requested. Not unless you request based on knowledge that actually, I just want to confirm for sure that yes, this is the case, but not based on lack of information. That's why you're requesting for that same set of investigations. And again, the turnaround time that you take to serve this patient. So if you already have this information, and you already, the patient is also presenting some other set of presenting these conditions, then you'll be able to make very quick decisions to be able to help this client. So that is the overall vision that we have in terms of improving the quality of care to our patient. Another important aspect we are trying to address is the question of accountability of the commodities that we have. Commodities are very important when you're talking about the HPTs. And the current situation that we have now is that like for KEMSA, they are able to track commodities, and this is what counties are actually struggling with. They deliver the commodities to the facility level, but they don't have any form of visibility beyond the facility. They don't have the utilization of commodities. They don't know when to reorder. But with the system now, because it's a transactional system, people are being served through the system, you are able to track commodities up to the patient, up to the mouth of the patient, meaning that at the click of the button, you're able to tell how much of some medication that has been consumed at any given time. So the question of visibility is really going to be improved. And as we are doing this, we are going to collect data in a very structured manner that is going to help to make day-to-day decisions, and of course help in formulating policies that are going to improve on healthcare delivery in this country. And so with this data, you're able to plan, you're able to come up with the analytics that you can be able to have trends and patterns that can inform critical decisions. So that then we start again slowly moving from curative measures, because now we have this data and we are talking about big data here now. You can now start slowly moving from curative measures to preventive measures. And this one again goes into actually delivery in the country. And another aspect that the system is going to address before I get to the core of the subject today is the aspect of we have very good policies as a country, well documented, but there's a very big gap when it comes to implementation. And the way we've designed the system is based on the policies that are there. So it means that the system, the platform, is going to help us facilitate the implementation of these policies. If there's a particular SOP that has to be followed, then that one is enforced within the system. And if people are using the system, then you can see now we are able now to implement these policies sometimes, which are very difficult to implement. You go to a facility, it's the same level. You're in a level 4 facility, different facilities, they are doing things differently. There are no standards that are being followed. And these ones actually end up people making mistakes that are not supposed to be made. So that is the general idea of having this system. And at the end of the day, we want to, like in the money industry, the banking industry, people are able to access their money whenever, wherever they want it, without any restrictions in terms of time, in terms of geographical boundaries. You have access to that information. That's what we also want to achieve within the health sector. So today, after giving that background, now we can shift our focus to the digital health platform. I mean, to the integration and interoperability. And actually, the platform is at the tail end of development. We are in the process starting towards the end of this month. We are going live in one of the facilities to start piloting before we start thinking of scaling up. Remember, like any other product, it has to go through the maturity process. We've done a number of engagements with the users. We first had our user acceptance testing in Naivasha sometime back in June, where we got a lot of feedback, which we've been working on to incorporate within what we have. After that, we've been working closely with the individual departments. We are talking about the lab, radiology, clinicians, MCH, all these departments within the facility, doing targeted validation of the product. And now we feel like we are comfortable to start piloting the product. And we hope before the end of this month, we'll be in one of the facilities in Kajiado County to have this product implemented. And one other thing that I could want to mention is that when we're talking about systems, a system is composed of 3 components. There's the hardware, there's the wetware, and there's the software. So, and this is a 3-legged stool, meaning that when one component is not working, the entire system is not working. So there must be proper hardware. We are talking about end user equipment. We are talking about connectivity, internet connectivity. We are talking about structured cabling, all this hardware that is required, power, backup, generators, and all that should be in place. Then there must be a user. The wetware here, we are talking about the user. The user is part and parcel of the system. It is the most important component, actually, when we are talking about the system, because the system is as good as the user. And therefore, we have to involve the users in the entire process. That's why in whatever we've been doing, the user has been at the center to ensure that whatever we are doing speaks to the needs of the user, that the system is going to fit into the environment. So there's also the issue of change management, because people like change, but they don't like to be changed. And therefore, they need to be involved. There's a need to change their attitude so that they are aligned for us to be able to achieve what we want to achieve. Then another thing is now the software, where now the one that automates the business processes within a given environment. So these three components are very important. They must be in place for the system to work. But the most important one is the user, and that's why we need to focus, because technology is never the problem. The problem is the user. And if all of us focus on the user, then we'll be able to, we give the support that he needs. If there's any capacity building that is required, it is done. If there are any issues in terms of support, they are resolved in a timely manner, so that the user does not feel frustrated, does not feel like he's been left alone to struggle with what we've deployed. So if all of us focus on this, then it's going to help really in ensuring that then we have a seamless implementation of the product. So now back to this topic, we are talking about integration and interoperability. As a ministry, we are mandated under the Health Act 2017, Section 105, to come up with a comprehensive integrated digital health platform, digital health information system. So I've talked about the comprehensive nature of the system that we are coming up with. Now today we are focusing on the integration. And as I've said, you go to a facility, they say they're automated, but those systems are not talking to each other. Data is not being shared across. And of course, for data to be shared, there must be some level of standards. And so that's what we're going to discuss today. How do we achieve this interoperability? What is interoperability? What are the steps to achieve that? And what have we done as a ministry to be able to ensure that then we have systems exchanging data in a more seamless manner? Next, Daktari. If you could move to the next slide, please. Hello. Thank you very much. So, yeah, next. Thank you. So we are talking about interoperability. And when you're talking about interoperability, it means that the ability of different systems, different devices, there could be lab instruments, radiology instruments, and any application within the ecosystem able to exchange and access this data in a manner that then that can allow a seamless and a timely portability of information across different across different systems that are there to allow for seamless sharing of this data. So there must be that capability to have all these devices, all these systems that are within a given ecosystem to be able to share the data that they have in a manner that they are able to make sense. But for us to achieve this health data exchange, we must have architectures. We must define an architecture through which then everyone must comply, because there must be some sort of standards in terms of
Jared, I don't know if I can't hear you. We've lost you.
someone is
Jared,
unmuting. Hello.
Someone is muting you or unmuting you.
Yes, I don't. Someone is muting me. Yeah, sorry.
Okay, sorry about that. I don't know who would do that, but you're unmuted now. You can go ahead. Let me
Yeah,
share the
and
screen
my
again.
slides
Yeah,
just share.
I had to stop because I wasn't understanding what was happening, but I am
Yeah,
just
today I
doing
think
that in a few minutes. It's a typical case of it has its challenges, but it has better out the yeah. So we're on this slide.
yeah,
Go ahead.
I can't see it from my end. So, but we are talking about interoperability, and we are saying, what is this interoperability that we are talking about? We are saying is the ability of different systems, devices, and when I'm talking about devices here, we are talking about the lab instruments, any instrument that is used within the facility, and any application that is there to access, exchange, integrate, and cooperative use this data in a coordinated manner. That is the whole idea about interoperability. And I've also said that in terms of interoperability, for us to achieve this health data exchange, we must have defined architectures, application interfaces, and standards. This is what will really enable us to be able to access and share and have this data shared in an appropriate manner that then can be consumed across the entire spectrum. So we'll be focusing our discussions more on the architecture and the standards, because at the end of the day, that is the foundation of integration and interoperability. You will not talk about integration and interoperability without talking about standards. And so, as I've said, the standards are going to be based on the architectures, application interfaces, and the general standards in terms of terminologies and all that. And interoperability is classified into four levels. We have the lowest level, which is foundational level, that is talking about interconnectivity, because there must be interconnection between different systems for the communication to take place. So there must be internet. Even if it's within our facilities, there must be some wireless connection, or there's wired within the LAN. There must be some sort of connectivity for us to even start talking about interoperability. That's the foundational layer of interoperability. So before we even start discussing any interoperability, there must be connectivity. So again, this goes into the question of infrastructure that I was talking about. Then the second level is now to define the format, the syntax under which this information is going to be exchanged within different parties within the ecosystem. So that has to be defined, and everyone participating within the ecosystem must comply with the format, because at the end of the day, if you send this information in a format that is not understood by the other party, then you're not communicating. You won't be communicating because the other party will not be able to interpret. At the end of the day, you are sharing this information for it to be interpreted and be consumed at that level to serve the client. So if you send the information in a format that then is not understood by other parties, then you won't be achieving the interoperability. And therefore, the formats must be defined, and must be people, the parties involved, the systems involved must conform to this format. Then there's the bit of syntax. So that you've defined the format, then you have to define the meaning of the data that is defined, and there must be a common understanding, so that then once this data is shared, then there is a common interpretation of the data that is being shared. For example, you have Mombasa is coded as 001. Then everyone within the ecosystem should be able to understand wherever it says Mombasa as 00. Whenever it says 001 for county, automatically it means that is Mombasa. But in a situation whereby 001 could mean Nairobi, Mombasa, wherever, then once that data is shared, then it becomes ambiguous. You cannot be able to say for sure that this one means Mombasa. And that's why then we have to have a common understanding and a codification of this data that then has the same meaning once it is shared across. So then again, we have to comply and understand that, yes, when I see this is what it means. So the semantic of the data that is shared must be properly defined, must be properly governed. So once we've defined all this, then this is the bit of the organizational, which is the highest level in terms of interoperability. there must be governance, because there must be a team that now defines the syntax, the structure, the interconnectivity of all these systems within the ecosystem. There must be policies well defined, the legal framework, which is very important. When we are talking about sharing of patient data, and within the legal framework, it is actually classified as sensitive data. So this legal framework has given us ways of how this data is supposed to be consumed. Who is supposed to consume it, how is supposed to be consumed, where and when it is supposed to be consumed. And of course, if you violate, there are consequences. And it is very important and that all of us who are within this ecosystem to be able to familiarize ourselves with the legal framework, that is to Data Protection 2019, that spells out who is the data subject, who is the data owner, or the data controller, the data interpreter. We need to have all this properly understood, because actually that gives the foundation from the security protection bit of the data, the foundation where everything is going to be based on. And remember, when it comes to data security, the biggest security around this is actually the law. That gives the biggest security. Then we have the technological bit, and of course we also have the user, who is actually in this space is the weakest link when it comes to data security. And therefore, they need to be sensitized to be able to understand how to manage the data that is being shared across. So that governance must be there to manage now the entire spectrum of data integration and interoperability of the systems. Next.
I've switched.
Thank you very much. Then the next thing that I want to talk about is health information exchange. So this is where we provide the capability to have clinical information electronically moved from one disparate information system to another system while maintaining the same meaning. This is what I was talking about. So even as we share this data, it's not just a matter of sharing. We have to share this data in a way that then makes sense on the other side, so that then you can be able now to have a meaningful communication. Because if you're not able to interpret what is being shared, then there's no communication that is taking place. So health information exchange provides that capability to have the clinical information of our patients that is in different disparate informations being shared, but not just only being shared, but have the have this data interpreted in the same manner it was intended to be interpreted from the sender. Then, so what is the overall goal of information exchange? Is really to facilitate access and retrieval of clinical data to improve on the quality of care. Because as we've said, we have a big problem of patient data portability. This information is not available, and therefore we're not able to give quality of care. But if this data is available, based on the example that I gave when I started this presentation, you're able to really be able to improve on the quality of care, reduce on the cost of service delivery, and even in terms of the turnaround time to serve these clients. So that is the overall goal, really, to have this data exchanged. Next.
Done.
Wow, it does not move from my end.
It's on interoperability standards.
Okay, yes, so as we've said, when you're talking about interoperability, we must talk of standards. We cannot talk about interoperability without really talking about standards, because standards really provide that common language and a common set of expectations that will allow now this seamless sharing of data between different systems within the ecosystem. So the standards provide a common language. And for us to be able now to exchange this data, we must speak this common language. And of course, then within the common language, we have the same expectations, the same interpretation. So standards are very key, and we are going to see how we are doing this to ensure that we have standards that actually have the same meaning, will have the same interpretation when this data is shared. And so when we have these standards in place, then it doesn't matter if all the systems within the ecosystem, like in the country, all the systems comply to the standards that are there in terms of the syntax, in terms of the semantics. I think there's a problem. Okay. Sorry. Yeah. Sorry for that. I think today there's a problem.
I was getting worried when I saw you left, man.
Yeah. I don't know what is happening, but I'm back now.
It's okay, as long as we're still on and we can still hear and
remember,
see.
we are saying we must have a common language, just like the way now I'm communicating. If I was communicating in my mother tongue, I couldn't be able to really be passing the message to the audience. And that's why we are saying now, for me to communicate, for me to make this presentation, I must use a common language. And that is a language that is understood by everyone within the ecosystem. And that's what we are saying, that for us to achieve integration and interoperability of the systems, then we must speak the same common language, that we have the same expectation, that we are able to make, we are able to interpret and make sense of out of the information that is shared. And so if we have these standards being complied by all the systems within the ecosystem, then it won't matter who is the supplier of this system, because they just come in, they plug in, and the data is we are able to share data from one to another. So the driver of really integration, and this is what I really want to be understood in this presentation, is that there must be standards. We have to comply to these standards. Then we have different types of standards. We are talking about vocabulary terminologies. This is where we define concepts that then can be shared between the sender and the receiver. And when these concepts are defined, they are coded, they have the same meaning across between the sender and the receiver. And we are saying that this then provide the fundamental requirement for effective communication, because without this vocabulary defined and used across different platforms in the same manner, then we cannot be able to achieve the integration that you're talking about, the interoperability, the communication that you're talking about. Another standard is to do with the content. What content needs to be exchanged, because not everything that needs to be exchanged. So we need to define that what data that needs to be exchanged, in what structure, in what organization, that this data needs to be exchanged between different systems. There's also the question, how do we have this data transported? Because all this must be defined really to be able now to ensure that then we are having data being shared across different platforms. So in what format is this data exchanged between the different systems, between the different devices that exist within the ecosystem? That also has to be defined. Next. Then there's the question of privacy and security, which is really very important, because privacy and security is really to protect the rights of the people that we are collecting data from. And for us to achieve this, it's very important to define what is the purpose of this data, when are we supposed to use it. This information must be properly defined. And that's why we say within the Data Protection Act, and actually this is properly defined in the Data Protection Act, that the owner of the data is the data subject. And in this case, the data subject is the patient. And therefore the patient needs to be told exactly, why are you collecting my data? For what purpose? That really has to be defined. And within the Data Protection Act, they are saying that if you are you are just a custodian. In this case, the government is the custodian of this data. And of course, you have the data, they need to sign a contract with the data protection commissioner that yes, we are collecting this data. This is the purpose we are collecting this data for, and you should only use that data for that purpose, and you should just collect enough data to be able to achieve the purpose for collecting that data. You don't have to collect more than you need for you to achieve, just good enough to be able to achieve. And of course, we have the data interpreter. So you can, the data controller can actually contract a data interpreter, and therefore there must be some data sharing agreements being shared to ensure that then we protect the rights of these individuals whose data has been shared to us. So as we speak, we have that standard is properly defined. So from the legal perspective, from the security perspective, we are well protected based on the 2019 Data Protection Act. The last type of standard that is very important is the identifiers. This is very important, and we are talking about unique patient identification. We have health providers identification. All these entities must be defined, must be uniquely be identified, so that then we can have, we are talking about longitudinal tracking the patient service delivery in a longitudinal manner, so that then you have this medical history that then you can be able to use to make very informed decision as you serve the patient. This is very important. The same case to the health providers. We need to have this information. We need to have these registries in place to help us to uniquely identify, so that we know that this service was actually offered by is able to create a unique patient ID that then can be used across different platforms when we serve the patients. One of the biggest problems we've been having is that you see, when every client goes to at any given service delivery point, there must be some sort of registration happening every other time, and this registration might not be consistent. So even within a given visit, you cannot compile services that have been given to this patient and associate it to a particular patient, because the way this information is captured is not unique. So you cannot tell that this data that actually belongs to this patient. But with unique patient identification, you're able now to track, and if it's used consistently, you're able to tell actually this patient came to this facility, he was served, he took this much time in this service delivery point, he was given this set of services. Even if there was any form of reactions, adverse events, you're able to track all that up to the patient level. Another thing that is very important when it comes to unique patient identification is that the turnaround time that is taken, as I've said, every time you go to a service delivery point, some sort of registration has to happen. But now with the patient client registry, the patient is registered once. You don't have to register again. We just reuse that data across. So we are going to save on the turnaround time that is taken to serve this client. Next. So what have you
Jared, I think we've lost you again. Jared?
Oh,
Yes,
yes.
I can hear you now. I don't know what happened.
It keeps on disconnecting. I don't know. but sorry for this, but we are about to finish. So we have I'm talking about the NHDT, that is Kenya Health National Data Dictionary, and that this is where we are going to define all our standards, properly defined, given the meaning, they are coded, and it becomes our single central reference. So that if you want to participate in this interoperability space, then you have to consume the terminologies that are defined within this dictionary. The dictionary is actually up and running. If you could go to the next slide, please. So what is the objective of defining, creating this national health data dictionary? As I've said, for us to achieve integration, we must have a common language. And so our common language is based on this platform that is created. So that then it's able to provide a single source of truth. That's the reference point. That if you want to, if you want to interpret any concept, any terminology, that's where you go and get the meaning of that terminology. And of course, with these now terminologies, these standards defined at the national level, and they are being consumed by different systems, then that way it powers the interoperability that you're talking about. Because now we have a common language that then we can be able to speak and be able to interpret in the same manner, because you can share the information is interpreted differently. The idea behind this is that we have a way of sharing this data, and that the way it is shared, the interpretation should be the same. That's when then you're able to achieve this interoperability. Another issue that the data dictionary is going to address is mapping to the international definitions. So we have our local definition, then it can be mapped that actually this definition means the same thing in this standard at the international level. So then that backward compatibility you are able to achieve with this platform that we set up. So if code 01 at the international, we are talking about maybe ICD-11, given classification of the disease. This is how it is codified within WHO. The same one, it is mapped to how we are codifying the same thing within the national level. So even now, when we are sharing this data beyond the Kenyan boundaries, we are able to map from the national standards to the international standards. The system is able to help us achieve that. Then, of course, once we have this data now coming into one pot, then we're able to interpret, because it means we have the same understanding, we have the same meaning as it has been shared from the sender. Then we're able to come up with reports, analytics that make sense to us without really misinterpreting what has been shared. Just as I gave you the example of Mombasa 001. So if you have Mombasa 001 in some set of records, and we have one meaning Mombasa, another one meaning Kajiado, then so the interpretation you see now, that one is going to be interpreted as if it's one county, and yet from the different sources that you received this data from, they mean different things. But if we follow the same standards, we follow the same terminologies with the same code, once we see this data coming into one pot, into one central repository, and we analyze this, it will mean the same thing. And so therefore, we won't have that misinterpretation of the data once we have the data analyzed. Next. So what is the end goal really? Is to have a nationally validated, semantically rich, controlled terminology registry based on established standards such as ICD-11, Service Master Drug Registry, so that then we can have meaningful sharing of the data. That is the end goal of the NHDD, that is the National Health Data Dictionary. So this is where we are going to define all our terminologies to allow now seamless sharing of the data. Next. Stop the slide from your end, Daktari. Hello, Doc.
I'm here. I don't know. Maybe somebody had interrupted it, but I think you can see it now.
Yeah, thank you. Yes, if you could move to the next slide. Yes, so how are we managing this dictionary? As I've said, we've defined the platform. It is based on an open concept lab. Is an open source terminology management system that we are using within our data center. We decided instead of developing something from scratch, and we already have some of these open source tools out there, we adopted the open concept lab terminology management system, which we've already set up within the ministry. It's up and running. We've already seeded most of the data, most of the terminologies. What we've done, we've tried to domesticate these services from the international standards. We're talking about ICD-11, LOINC, SNOMED, all these now, we have our own codes in as much as we are mapping them to the national standards. So that then we have that free control of adding the terminology that might not be existing within the international standards. That's the purpose of translating into the national standards and having them coded based on the national codes that we are going to have. So the platform is available. You can access it on nhtd.health.go.ku. You can search for any terminologies, and you can see different sources of these terminologies. We have the sources, a source like NHDD, that is now our national source. We have WHO as a source. We have SEAL as a source. We have SNOMED. We have LOINC as a source. But all these sources, the international sources, have been mapped to local standards, that is, which we are naming NHDD. And we are saying now, for us, when we are consuming these standards, let's consume the national codes that we've defined. That is under the NHDD source. Next. And this is the interoperability architecture. We say that we have to have architecture, we have to have application interface, we have to have the standards. We've already covered the standards that we are going to use. We are talking about the registries, we are talking about the terminology services that is really the foundation of integration. And now we must define the architecture. The architecture is very important. And again, all these, for us to achieve the integration, we must comply to this. So we have the registries here. On my left, you can see that. We have the client registry that I've said is up and running. We have the facility registry. Again, we have to uniquely identify our facilities. We have the Kenya Health Master Facility that codes all the facilities across the country, given classification, physical location, their geographical information. All that information is defined. So that then when you see data from a given code, you already know that actually this data is from Kenyatta, this data is from Malusi Hospital. And without that standard, and that standard is not followed, then when data comes, you can't even tell that actually you won't have the same implementation. And I hope now you're starting seeing why there's need for standardization, so that then you can have the same interpretation of what is being shared, and that we must consume from the same standards for us to be able to have the same interpretation. And of course, we are talking about the terminology registry. This is where we are talking about the NHDD, where we are coding our concepts, our diseases, our procedures. They are well coded so that when you see maybe 001 means Panadol or means a particular lab procedure, and if that information is shared, is the same, it means the same across. And of course, you also need to have a health worker registry. And all these registries are up and running. There's a gap within the terminology service. We've not defined all the terminologies, but we are in the process of its continuous improvement. We are going to have a governance team that is going to look at these terminologies. We are even setting up a training module so that then people can start understanding how to consume from these terminology. We are even coming up with a website documenting how any person who wants to participate within this ecosystem, what he needs to do to be able to start participating within the ecosystem. So that then we have a common understanding, and that then we can be able to have these signals. So once we have these registries, then we have, at the point of care, we have different systems. So it won't matter which systems are out there, as long as we are consuming from these standards. We are consuming from the registry services. It won't matter the kind of systems. Then within the systems, we are saying that we are going to have an interoperability layer that does the coding, the decoding. Because like for example, we could be having systems that are already there being used, but they are not compliant to these terminologies that you've defined. So it means that within the system, they need to translate their data into the common language that you've defined before sharing. And we are saying when we are sharing, this is where we are talking about the syntax level, the structural level that we are talking about, which is the second level. How is this data shared? And we are saying that we are going to use FHIR. FHIR in this case stands for Fast Health Interoperability Resource. It is a building block that defines the minimum amount of data that can be shared from one source to another. So as a country, we are adopting this as the format that we are going to use to share the data to the central repository, which we are calling the shared health record repository, where all the data now that is being generated from the various service delivery points using different health information systems is going to be shared. And so if because now we already have the patient data here, the client data, and that client data is associated to the facility, and all the services that are offered are associated to the terminologies. So if this data is shared here, if this the same person goes to another facility using a different system, now that we have the same standards, we have the same patient ID, that information will be retrieved from the national repository, and and it will be taken through the interoperability layer here for decoding, because maybe the way this data is understood, because there's something you need to understand. If these systems are natively supporting these standards, then there's no need of this, because as this data is shared, it means the same thing. But in a situation whereby you are using different codes here, then at this layer, you need to translate this to the codes or to the terminologies that can be understood in this platform. But when you are sharing again this data to the global platform, and you have to translate it in a manner that can be consumed by the rest of the people. So, and that's why we have this layer to allow for conversion and translating this data wherever you are sharing and whenever you are consuming. So whenever you are sharing to the national level, you have to use the common language that then can be understood by the rest of the players within the ecosystem. And whenever you are consuming now from this level, if your system is not natively supported by these terminologies, then again, you have to translate in a manner then you can be able to consume within your platform. So this is the architecture that we have. And the take home here is that we have the registries that we have to consume from, because this now provides the standards, the common language that you are going to use to speak and communicate across. Then we have the FHIR here, the FHIR resource, which defines the templates on how different data sets are going to be shared. So for example, you're talking about observations. You're talking about procedure requests. What kind of information, minimum information that must be shared? In what format must that one be shared? What are these data elements that must be shared within that particular message that is being shared? So that has to be defined, and we've already defined all that. And we are saying that we are going to follow the FHIR standard. And as I've said, FHIR stands for Fast Health Interoperability Resource. It is a template that defines the format which data is going to be shared within different systems. Next. The next slide, we are going to talk about the client registry. And this is where we are saying, as you have said, as a country, we've been having a problem in uniquely identifying our patients, and that actually sometimes it takes longer. It takes longer to do registration than the actual service someone has gone to seek at any given point. And of course, that we are not able really to track medical history of the patient, because every other time the patient comes, is given different identifiers. But with the client registry, we are saying we are going to have the client registered once, and we use the same unique patient ID to serve the client across different service delivery points, across different facilities. And that this data is going to be shared in a common repository, and then can be consumed by different systems within the ecosystem. So for us to be able to generate this unique patient ID, we must share to the client registry some minimum information. And this minimum information includes personal information. We are talking about the name, the identification details, the national ID, passport, birth certificate, alien ID, all those national identification documents that are recognized by the government of Kenya. But we are also saying that for the sake of a seamless implementation of the client registry, we are saying that if we are Kenyan, an adult Kenyan, then we use the national ID as a default. You could be having your passport, you could be having your driving license, which is a form of national identification document. But within all these other documents, the primary document here is the national ID. And we are saying that, so when you're registering this individual, in as much as you might go ahead and capture these other types of identification, we give priority to the national ID. For the minors, we are saying we use the birth certificate. There could be other form of identifications, but yes, we use the national ID. I mean the birth certificate number. For the foreigners, we have the passport number to be used to do the registration. So once this information is posted to the client registry is now able to generate unique patient ID, then that can be shared across different health information systems. One thing I could want to point out is that for us, this is really a stopgap measure. We hope once we have Huduma number really fully operationalized, then we won't have these issues of unique identification of the patient. Because with the card and the biometric identification of the patient, then you are able to identify this patient at each and every service delivery point. But for now, this is a stop to help us be able to improve on service delivery. Next.
Next, I think it's finished.
Thank you very much. That marks the end of my presentation. Thank you very much. I hope you enjoyed. I take back this to the chair of this session. Thank you very much.
Thank you, Jared, for the many for the remarks. We have a lot of questions, and we'll start addressing some of them as soon as we can. Let me just go through some of them so that I can have methodology towards how I'm going to ask. So Assam has a lot of questions. He's asking regarding the if it is an end-to-end digital, if it's an end-to-end digital platform that has national guidelines on management of various diseases, and will the system be, how will it be financially maintained so that it's sustainable? And also considering the fact that many counties have procured their own EMR. So maybe you can address that as one. Thank you.
Thank you very much. That is really an important question when you're talking about sustainability. And actually what we are doing is really towards addressing the question of sustainability, because we are talking about we need to come up with resilient, sustainable solutions for health. And one of the ways is that the government has taken to address this question of sustainability is that Yeah, it's that this system is homegrown. It's actually developed internally within the Ministry of Health. And that way, then we have the full control of what is happening. The system is fully financed by the government, and that it is 100% owned by the government. And actually, some of the things that have been done towards this is that we've also set up a state-of-the-art data center. As I said, that we must have proper infrastructure under which then we are able to implement this system. So there are a lot of work that has gone into addressing the question of infrastructure. We have a data center that is up and running, and that's where we actually, most of our systems that are running, and I didn't mention these, that we have other systems apart from DHP that we've developed. One of our systems, a successful project that we've implemented is a Chanjo system that we used to facilitate the rollout of COVID-19 vaccination. And the way we designed it is that is actually we can be able to scale it to allow vaccination for routine immunization. And we're actually in the process of doing that. Another system that we've also implemented, which is very key, is the blood management information system. Again, it's running within the infrastructure that we've set up. This system, you are able to actually track blood from one vein to another. Today, you're able to tell that blood that was donated by person X ended up to person Y. You're able even to monitor hemovigilance after transfusion. So we've implemented the platform in all the regional blood banks. We are in the process of scaling up in the satellite blood banks. That is vein 1. As we start scaling up on vein 2, vein 2 is already working in KNH-UoN. I'm also informed that it's also working within Chogoria as a faith-based facility, and we have the MTRH as we scale. But of course, vein 1 must work before we talk about vein 2. So those are some of the systems that we've done. So to address the question of sustainability, then yes, that's the approach the government has taken, that we have to have these homegrown solutions. Because some of these solutions that are actually bought, when for example, you don't pay for the licenses, you end up losing even your data. So there's vendor locking, there's the question of standardization, the systems might not be talking up to each other. And that's why we are saying that the government actually is taking the lead in developing the systems. But we are also saying that to avoid disrupting what is already there, we are creating the interoperability layer, so that the systems that are out there that are already being used by different counties, they can also participate within this ecosystem. At the end of the day, the objective is that we want to improve on quality of care that you are given to our health workers, to our clients who are the patients, and really going to lowering the cost of service delivery. So yeah, that's what I could say about that answer, that question. Thank you.
Thank you very much. We have other questions regarding data protection. So we're being asked if, sorry, let me just get it. What security for data protection and confidentiality assurance? And also, what is the avenue for cross-border breach of data protection?
Thank you very much. That is a very important question in terms of data security. And when you're talking about data security, and just before I answer this question, because it comes out in all the forums that when we engage various stakeholders. Currently, as we speak, we have our data in files stored in a room. Some of these rooms are not actually closed. Someone can walk in and walk out with the files. There's no clear control actually. At that level, actually, there's no security that is provided on these files that are being stored at the facility level. Having said that, when you're talking about data protection, there are several layers of security. One of them is the legal layer. which we are talking about, the Data Protection Act 2019, that provides a framework that manages, that guarantees privacy, rights to privacy to our clients. Clearly, within the Data Protection Act, it stipulates that health data is classified as sensitive data, and therefore any sensitive data uh, must, people who are handling this must comply with the Data Protection Act. That is layer number one. Layer number two is the security, the physical security. Under physical security, like where we are storing, where within our data center, even within the facilities, we are saying that the access to these server rooms, access to the data centers must be controlled. There must be a biometric access. There must be CCTV surveillance systems. There must be guards who are there to ensure that then they control who access, and there must be some logs to keep track who accessed when that particular facility. And at the national level, within the data center that we are talking about, all those things have been put in place in terms of physical security. Then another layer of security that is very important is the logical layer, where we are talking about the firewalls that really can even be offense. Like as we speak now, for change of system, you cannot access it without outside the boundaries of the Kenyan boundaries. You can only access it within our boundaries. So we can do geofencing of our public IPs that you can only access the system within the Kenyan boundaries. So the firewall is able to track and filter all the traffic that is coming in. If, for example, someone is trying to spam, we have spamming rules that we put there that can suspend that and notify us. So the firewall is there. We have other layers within the systems. We are also talking about, under the logical layer, we are talking about data encryption. When this data is being transmitted, it is encrypted so that even if you're able to tap into this data that is on transit, you cannot make sense out of it. At the same time, once it lands at the data center level, data is also at rest, is also encrypted. And even now at the application level, we have roles given to different actors. If you are, for example, you are an HRA, or maybe you are doing registration of clients. So you can only do registration of clients. You cannot do beyond that. And you are given your user account, username, that then that is what you're going to use to be able to serve. And we are able to track the services that have been offered, that each and every action that you've taken within the system. So we have all these, and the system, for example, for the DHP, the user roles are really very granular. We can actually say you can only do registration, you can modify, you can delete. So we can be able to say for you, you can only register. For this other role, you can only register and modify. You can only also, maybe you cannot register, but you can modify a record. And we keep audit logs of all these activities within the system. But as we talk about the one last thing I could want to say is that in terms of technology, in terms of the legal framework, I think we have the foundation that we guarantee data protection. The weakest link that we have in terms of data protection is the user. And that's where we need to focus. And so our users needs to be sensitized on Data Protection Act, the data issues of sharing of passwords, policies, and all things to ensure that then we all comply to the Data Protection Act and ensure that we guarantee the privacy rights to our clients. Thank you.
Yeah, thank you. And maybe just to note, the Data Commission has already started getting reports from hospitals, from patients reporting hospitals that we're not complying. So take it as a personal stake interest to know more about the data protection and know more about information security. So another question that I find quite interesting is regarding to human resource. Matthias is asking, are there studies done that demonstrate that? Sorry. Someone was asking how is it that it can improve despite the understaffing that is ongoing? Would the system help? Will it be a setback? Over to you.
Thank you very much. That's really an important question. When we have systems, actually, systems come in to improve performance of our users. So the outputs, the effectiveness and efficiency of service delivery within a given sector. That is the sole purpose of really systems, to enhance service delivery at any given point. So for example, we are talking about the turnaround time that I was talking about. There are several, like at the hospital level, you can imagine every other time someone goes to receive a service, he has to go to the cashier, pays, come back. That back and forth, you can imagine that back and forth. The time that is taken to serve this one client is too much. But if you have a system that is integrated with the payment, like with DHP, we are finalizing integration with the NHIF. We are also finalizing integration with the M-Pesa. At that point, you don't have to keep on sending this person to the cashier office to make the payment. You can make the payment and continue receiving services from that point. Another thing in terms of improvement of service delivery is, we are talking about, for example, registration. As I've said, every time the patient comes, he has to be registered. Look at the amount of time within the registry they take to retrieve a patient file. And sometimes they don't even end up getting it. The files are all over, even in terms of the space that is required to store this data. So when you look at the system, actually, it's coming in to improve on the effectiveness and efficiency with which we are delivering on our services, and really reducing the turnaround time as we offer these services. That is really the objective. Of course, there are those challenges with the human resource. And for me, this has been a concern, whereby most health workers, this is the observation I've made, that once, for example, they've vaccinated, they've done their bit. But your work is done when you've done documentation. You've done it and documented, because it's not just about doing it, but there's also the bit of documentation. Just like when you go to the bank, you are served through the system. You cannot be given your money. Then the teller at that point, he says now he has done his work. That work is not done until he records, or she records, that actually I've given out this money and your account is debited accordingly, or I've received this money and therefore your account is credited accordingly. So documentation is part of the work, but of course we understand and appreciate that sometimes they are overwhelmed because of the number of the number of patients. The traffic that is there is too high. So sometimes that's why they feel like, as long as nimemdunga shindano, I think I've done the most critical bit. But documentation is also equally important, because without this information going forward, then you are not going to serve this patient better. So even as we proceed with this conversation, I think it's important that we emphasize on the bit of documentation as it's being our work. Thank you.
Yeah. So, Jared, we have another comment from Peninash. First of all, she says, way to go when we have our home ground solutions, and truly way to go. We are here to support you. And a very interesting thing she points out is about the geometric border, especially for the vaccine. So she's asking, with regard to the access from within the borders, I think we must think for the next phase, especially for individual access, maybe in partnership with immigration, for people to access the information from outside Kenyan border. So what do you think about that? Thank you.
Okay, in terms of vaccine, there are two things. We have the change of system that is used at the facility level, and we have the patient portal. And I didn't talk about this. The patient portal is like the e-citizen for the Ministry of Health, where all services that are client-facing are going to be published within the patient portal. Because we are talking about patient-centric system, that the patient is part and parcel. he should be able to have access to the information wherever he wants it, without limitations of the time, geographical boundaries. So, but for the change of system that is used at the facility level, that's what will be geofenced. But for the portal, it's accessible across from wherever you are, because that is your information. Once you log in, you only see what just belongs to you. Thank you.
So, then others are asking how they can be part of this movement. How can we collaborate? How can we exchange ideas with the Ministry of Health in regards to this?
Thank you very much. I mean, whatever we have done, we cannot be able to achieve it ourselves. We need different players to come on board to help us. There are several areas. One of them is capacity building, which is really important. Change management, which for me is very key in the successful implementation of this product. Change management is very important. There's the question of infrastructure. It's a big question that we really need to address even as we go about implementation of these, because I talked about the three components of our system. We have the infrastructure, we have the user, and we have the software itself. And so I feel like there are opportunities in these three components to collaborate. But the measure that we have at the moment is the change management bit, that all our users, they are properly trained, their attitude is properly aligned. And of course, there's also the bit of the infrastructure, which has really a cost component in terms of the end user equipment, in terms of internet connectivity, and all those requirements. In terms of power, I mean, we cannot deploy this platform without power. So do we have alternative source of power to have this product implemented? And of course, at the product level, doing validation, given suggestions, like the way we've been working with Dr. Amin has really been instrumental towards achieving what we've done so far. She's been organizing a lot of meetings with different stakeholders within different departments, trying to validate what we have, getting feedback to improve or to ensure that really the system talks to the user as opposed to the other way around. So that then we have that seamless implementation. And it's because of these kind of engagements that now we feel comfortable to start talking about piloting. Thank you.
Thank you. Thank you very much. Another pertinent questions that I feel like a lot of people are asking about is faith-based organization and private facilities. Would they eventually be able to have access? Are they part, maybe you can answer, are they part of the pilot? Maybe some of them are already part of the pilot. So you can let us know.
Thank you very much. The product is available. Of course, as we said, the question of sustainability at the moment, the product it's not really free. It's being funded by the government of Kenya. But as we speak at the moment, yes, we've engaged the faith-based actually. CHAC is one of them, and they are really interested in this. And we told them just hold on. Once we finalize with the piloting bit, we are comfortable. And I hope actually starting next year, we should now start thinking of how do we start scaling to those facilities that have proper infrastructure, the users are properly aligned. How do we start having the product implemented? But we wanted this phase, as I indicated, like any other product, it has to go through the maturity process. So that's the phase that we are going through to stabilize the product, making it better. Before now, we can say that we have some level of confidence that now we can start scaling without really being thrown into a firefighting mode because of the number of facilities that you are dealing with, and maybe the issues that are that will be emanating through that implementation process. So we are starting small. We are applying an incremental approach. So as we learn our lessons, because this is really it has not happened, and therefore we are taking those baby steps as we learn and as we keep on scaling, as we guard this baby, because we don't want this baby to die. It's a very beautiful baby, and because of that, we are really very cautious, even as we go to start the implementation process. But I hope with the
Yeah.
support that is there, I'm sure we are going to deliver on and have this baby mature. Thank you.
So Jared, I can attest. Usually the first time is usually the hardest, even with the vaccine, and even with the blood currently, which is being enrolled, the vein 1 and vein 2. The process might seem tedious because it's a new experience in the first stage, but the second time it's so seamless, and how how the people have that information, how many times they've donated, how many times, like it gives you very good analytics about what's happening with yourself. And uh, and uh, and, and this baby is a visionary baby, and we hope we will all work together in collaboration. So someone also mentioned about Konza, and I believe it was in your presentation. Konza is currently up and running as a data tier 3 center. I believe it's there are only two in Africa, and it's actually accredited by Uptime. So what are your thought process on how we can collaborate on that? I've seen someone make a note on that, and you've mentioned it as well. So over to you,
Yeah,
Jared.
just before I respond to your question, on the question of maturity, I want really to agree with you. Like now for change system, we don't even think about it. People are doing their own things out there. They're able to train. We have a training environment. They're able to manage their users. They're able to do their own supports at the county level without us being really directly being involved. For us is to ensure that the platform is up and running, it is working. And of course, during the initial phase, there was a lot of support work that we were doing. But as people get comfortable navigating through the system, as the system also matures, because there are other scenarios that were never handled, they were never seen at that point when we were deploying the product. But as time went by, most of these things were iron. People are comfortable. They can now do inter-support within counties, within sub-counties. And nowadays, for sure, I don't even, the last time I was called that there's a problem within the Chanjo system, I don't know. There could be, the only challenge is in terms of data, the correctness of the data that is captured. And that's why I'm saying, even as we move forward, our focus really of all of us should be on the user, because that's the most important person in this space. So on the question of Konza, actually, as Dr. you are aware, at the moment, the telemedicine that is being implemented within Kenyatta and the Isiolo Referral Hospital is actually housed within the Konza facility. So there are those collaborations. All these options are available, and wherever there's an opportunity for us to collaborate, I think we are ready. Because again, as I've said, infrastructure is very key. And for us to be able to successfully be able to implement this product, there must be proper infrastructure to support. But again, as a ministry, we've set up a state-of-the-art. It's a really good environment where we are housing our systems. But if there's need to extend the housing in terms of even backups, then all these options are there to ensure that there's reliability and availability of services across at any time, wherever it is required. Thank you.
Thank you. Thank you. Another pertinent thing, maybe it can be our last question for today, is regarding AI and predictive analytics in the systems. Of course, we need a lot of information in the systems to make it, but are there provisions to head there so that it can even alert us on probable diagnosis or medical errors? Is that something futuristic for the system?
Thank you very much. We are living in information age, that everything's driven by information. Decisions are being made based on data, and the data there's a lot of data that is being generated at any given time. And yes, that is really the purpose of why we are having this. But for us to be able to take advantage of the data and this information, first of all, we must provide a structured way of managing this data. That's the beginning, the starting point, the structured way. And we have the platform, we have the standards that we've defined. Then the next step now, how do we now use this data to provide decision support as care is being given? There's some sort of decision support within the platform as we speak, but there's room for improvement as we keep on getting more and more data. Another aspect, and which I talked to in my presentation, is the aspect of doing analytics. That where we are able to have these patterns, identifying trends within the data that is being analyzed, so that then from this you're able to formulate policies that are really targeted, that are really going to improve on service delivery, and more importantly, we start moving away from the curative measures to preventive measures. So we've just started the journey, and that is really the ultimate goal. As you know, for us to achieve AI, we need a lot of data for us to have the machine learning capabilities.
Yeah, the deep learning needs a lot of data.
We've started the journey, and we hope as we walk this journey together, we'll be able to achieve this. It's not going to be easy, but yes, we are ready to face. Thank you.
Thank you, Jared. So I wanted to, I can see Professor Anzala has his hands up. Professor, kindly go ahead.
Yeah, thanks. I've been listening very, very keenly. Gerald, this is great. Really, this is the direction that we need to take, because data is everything. From the research we've been doing here, data is actually just two things here. One, what is the status of KNH in terms of actually putting this infrastructure and ensuring that at every entry point, we have information on the patients, and as you've rightly said, it makes it easy for patient management. And number two, how will you manage the intersection between private sector and public sector? Because we know very well that patients keep moving back and forth between private and public, and then public sector. And then number three, the level of access. How do we ensure that there are structured level of access, so that people don't just get in and get information of patients here and there? So those are some of the things that I'd just like to hear you. Thank you.
Thank you. On your first question, I did get status on what?
Kenyatta National Hospital. How are we? KNH, Kenyatta National Hospital. How are we on this infrastructure that you are talking about?
Maybe I can take up the Kenyatta question, but Jared, go ahead with the others.
Thank you very much. I'll start with the last concern that you raised in terms of level of access. As I've said, and I think I will keep on emphasizing on this one, and I like that it's coming out in this conversation, is that the biggest link in terms of security is the user, is the person who is interacting with the system, and that the user is a part and parcel of the system. And so within the system, of course we put measures to ensure that you can only access what you're permitted to access. In terms of user access levels within the system, they are really very granular. As I said, you can be given access to just do registration, or you can do registration and maybe modify data, or you can do registration, you can do triage, you can go to the lab. All these roles are going to be defined and given to individuals based on their roles within that particular facility. Another thing in terms of level of access, we are introducing a two-factor authentication, which is really important, so that in case your password is compromised, again, a person cannot be able to access, because there's this other factor that you have to provide for you to be able now to access the system. So yeah, we put enough measures around this. And for me, my biggest worry is not about these access levels, the technology. And as I've said, the worry is the individual, because this is the same individual who will go ahead, share his password. Is the same individual who doesn't log out when he finishes using the system. So, and that's why even as we talk about security, we need to, as much as possible, really focus on the user to ensure that he understands why he needs to do what he needs to do. Then, on the question of patients moving from one facility to another, especially between public and private facilities. This is what I was talking about. And actually, the entire session has been on integration and interoperability. So we've defined the national data dictionary. We've defined how we've defined the client registry. We've defined the format which we are going to have this data shared. We've already created that national shared repository where now if you comply to the standards, because as I've said, for you to participate, for us to be able to have meaningful and seamless sharing of data that makes sense across board, all the participants within the ecosystem, then you have to comply to the standards. We have to use the common language. So from our end at the national level, we've created the national language, the common language that can be used. So it's the rest of the EMRs at the facility level to comply to these standards so that then they can be able to participate within the ecosystem. One thing, this work that is ongoing, as I've said, we're also going to publish this information on the website to make this information available on how different EMRs can participate within the ecosystem. The client register is up and running, the NHTD is up and running, the KMFL is up and running, the central repository is up and running. So we need to do the documentation and the people, there's a lot of work to be done at the EMR level to do the conversion to the common language. Because now you cannot just share data which is not in a manner that then can be consumed, in a manner that can be interpreted. So that's where work is for us to be able to achieve this integration and interoperability. But at the national level, we've set the standards. There's, of course, work to be done in terms of sensitization of what we've done. And this part of the sensitization that actually we are doing, people to be aware of what we are doing and how are you going to participate to be able to achieve the...
So for now, then it's only the public institutions that will participate, yeah?
We are not limiting. If the private is ready, we don't limit we are not limited. We are not giving any priority. As long as you are ready, at the end of the day, it's your readiness. We've already defined the standards. So comply to the standards and you're able to participate. And the basic idea for complying to the standard is so that we have common interpretation of what is being shared. Thank you.
Thank you very much, Jared. So Professor Nzala, regarding to Kenyatta, I don't want to say much, but we have already started piloting our e-hospital systems. So hopefully in the coming months, you'd see a lot of differences in the hospital. The ICT team is on top of it, together with the healthcare quality team, and most of the stakeholders, including Dr. John Kinuthia. And we are piloting the digital health platform in KNH-UoN, hopefully very soon as well. So keep an eye out, and we are happy to hear any feedback from you. So thank you very much, everybody, for listening to today's session. Jared, you've been very instrumental in many things. And Jared has also been recognized by the president in the last Makadara Day, where I believe it's Makadara, but he's a HSC. He got a HSC award for the many works that he has done. Kudos to that. So thank you very much, everybody, for listening. Until we meet again, that will be next week on Monday. We shall have more sessions and engaging. Thank you very much. Bye-bye. Jared, any parting shots?
For me, it's really, thank you very much for giving me this opportunity and for engaging me with those very wonderful questions. And this kind of engagement is going to help us improve on what we have to make it better. At the end of the day, the bottom line is really to improve on service delivery and really lowering the cost of service delivery to our clients. That is our goal, that really we are going to serve our clients better. Thank you, and really appreciate the questions and your time that you've given me to make this presentation. Thank you.
Thank you very much. We hope we hear from you soon. I think next week, if I'm not wrong, but we shall confirm. Bye-bye, everybody. Have a lovely weekend, and thank you for tuning in on Friday. Bye-bye.
Bye-bye.